Just going to jump into the COVID rounds update number 2. And to start that, I'm just going to ask Neil to give us the operational and leadership update. Thanks, Neil.
Thanks, Stuart. So everyone, I'm just going to keep my comments brief so we can get down to the important presentation here. I just want to kind of give a brief overview of what's happened. I think we're about 3.5 weeks in now since the first Calgary case. We had done mostly just thinking about what we do about this before the first Calgary case. And then when the first case showed up locally, we really hit the ground running. We, as you know, developed a pre-triage, which was important for separating out the infectious patients, and then all the emergency departments quickly developed plans to sort of separate themselves into infectious sides and non-infectious sides. And as we go forward with the controversies over PPE, I think having a really strong pre-triage is one of the biggest factors that correlate with decreasing transmission in the emergency department. So in addition to that pre-triage, we expanded our capacity in the emergency department, and then also expanded the capacity in the hospitals. The numbers I'm seeing are really extraordinary with regard to the effort made to clean out the hospitals. And it's kind of interesting to watch them clean out the hospitals. Like, there have been times when we've been asking for it and begging for it over the years, especially at South Health Campus when we had 50 EIPs, and they basically said they couldn't do it, and now it got done in very short order. It's not a criticism, it's just, I guess, the perception that this pandemic is much more important than our usual overcapacity state, but done it they have. There's big capacity. They're converting empty units at the Lougheed and surgical short stay units at a lot of hospitals into inpatient capacity. So the hospital capacity is really ramped up. We developed policies about PPE and workplace health and safety that have been difficult to communicate because they change. And I'll just have another comment about that in a bit. And then we developed clinical guidelines with the help of this clinical group and the Emergency Strategic Clinical Network. So we've got emergency as well as critical care unit and MTU guidelines for treatment. And then we started the pandemic planning sort of for phase 3. So phase 3 is going to be preparing ourselves for the increase in volume of patients. And that's the toughest part right now, because we have limited access to forecasting and projections. And what we have for forecasting and projections, it's very difficult to know, what's going to happen, what's coming in. So we're hoping for the best, but we're preparing for something worse than that. I don't think we can really prepare for the worst because it would be completely overwhelming to us, but we are preparing to increase the capacity of the emergency departments by increasing every emergency department's geographic footprint, and then increasing most significantly for us is developing some processes to deal with these patients quickly. So you would have all seen the admissions algorithm that came out of my last memo. I think it's now linked to the COVID order set. But it's a very straightforward algorithm for admitting patients. I've used it recently on shift. If they qualify according to the criteria there, you do a curve 65. They're oxygen dependent, and you just make one page to the COVID pager, and somebody comes down and admits them. It's really a remark. It's unbelievable to me that we got that through. Kasha Lens was crucial in development of that, but internal medicine and the hospitalists agreed, and so it's very straightforward. And so we're going to pair that admissions algorithm with the high volume setup in the emergency department, so that it will become, I think, quite straightforward what we do with these patients from an emergency department point of view. So we will be admitting them to MTU or discharging them, and the criteria will be pretty straightforward. good cardiopulmonary reserve, good walk test without hypoxia, and you can go home, perhaps without even any investigations. Poor cardiopulmonary reserve, maybe a little bit of hypoxia, some investigation, some observation. If you fail, you call a COVID pager. So our role in this hopefully will be pretty straightforward. We just run up against the unknowns of how many people in Calgary are going to become infected and how sick they're going to get, and how much we can bend the curve through these public health measures. So we're not sure what's happening there. Things are unfolding on a day-by-day basis. But we are planning for volumes that will at least stretch our capabilities and then beyond. I just wanted to mention one thing about the PPE. There was a bit of a misstep that was our fault, and it has to do with the decision-making capacity of leadership. We'd like to make our own decisions, but we're a bit handcuffed by the provincial processes. When the prevalence of the disease in the community started to increase, we started to think about using PPE for every patient encounter. And in the absence of clear direction from the provincial authorities, we decided one night last week to put out a memo to site leadership that we should be wearing PPE for every patient encounter. And then subsequently, we found out that that wasn't endorsed by the province. Now, I just want to reassure everybody that we've got expert teams working on this. Andrew McRae and Ian Walker, amongst others, are working with Dr. Conley and some other provincial leaders about just finding out what's the most efficacious PPE and what practices are going to keep the emergency department workers the safest. And then they're going to combine that with the availability of PPE and come up with a recommendation. So right now, I just want to summarize it. Like anybody that you're seeing who got screened positive for infectious disease, you're on contact droplet. If they're in the other part of the department, you just have to use some situational awareness. If there's a language barrier, if there's confusion, if they've developed fever or cough in between the time that they got triaged and you see them, then by all means, you should have contact droplet on. And I don't think anybody should think twice about using contact droplet for almost every patient encounter, or at least a mask and goggles and gloves. But you really have to attend to proper donning and doffing. It's much harder than when it's every discrete patient encounter and you know when to don and doff and how to do that properly. If you're trying to wear continuous PPE, it's very easy to touch your mask, to not take it off properly, to accidentally use the phone, things like that. So really attend to that. And sort of in the last thing I'll kind of say about that is that there is no patient emergency that is more important than the safety of our personnel. So please use PPE cautiously in terms of protecting yourself. And that should be of the very first priority. And I promise we will try and iron out the guidelines in a sort of, more comprehensive, easy to understand format as time goes on. So stand by for more information on PPE and our supplies of PPE, and stand by for more information on how we're going to increase our geographic footprint. Lots of people working in the background of all this. We really appreciate you guys out there seeing all the patients while we're pushing paper in the background and trying to make this experience sort of not catastrophic for Calgary emergency departments, which I don't think it's going to be. So keep our fingers crossed, and happy to answer any questions in the Q&A or chat box. Thanks.
Thanks, Neil. Thank you for that, for those comments. And yet again, we really appreciate what the leadership is doing for us in the background. We know that you guys are there for us and working so hard. Thank you. So just as I just reflected on this week, looking back, the way that things are panning out in pandemic management across the world, it just makes me appreciate how great it is to be living and working in Canada. I think that for me, this is a fantastic place to be. I really think we need to just reflect on that and value that. Can I have the next slide, please, Aaron? So just the agenda right now, Neil's done his operational update. Farine is going to give us the wellness update, and then we're going to jump into the clinical aspect. Brian is doing the airway management update. Then we're going to wrap up, and the reason we're going to wrap up then and then have questions and answers because we're probably going to exceed our time, and we want to be respectful of people's time. So in that half hour, we're going to try and get the update done. But then those that have time and are happy to stay, Sean will try and answer as many questions, especially the top 5. So we can just have the next slide, please. So just to go over the working group updates, just the principle behind it, just to remind everybody, the purpose of these rounds are to help people, frontline clinical workers, to manage the COVID patient when they hit the door. So to try and give clear, simple advice, using mainstream evidence, but then where that's not available, to use local expert opinion. And so just keep this in mind that if you're not watching this webinar today, things may have changed already. And so please reference your local guidelines, because we are trying to put things out and they are changing, as you know, on almost an hourly basis. So please keep that in mind. Next slide, please. Okay, and then just as far as the questions go, please send in your questions using the Q&A function on your screen. Check the questions and vote for them using the little like button. That will then move the question up in priority. And depending on the time, Sean is going to be collating and answering those questions, or drawing in panelists to answer the questions. But we'll try and get to at least the top 5. And as I said, that's going to happen after the half hour. That's what we anticipated being. So keep that in mind as we go through the presentation. Next slide, please. And so now I'm just going to hand over to Farine to do the Wellness Hub update. Thanks, Farine.
So thanks, guys, so much. Hopefully, Sean's Grand Rounds was a nice break from thinking about COVID 24/7. Quick reminders, these are all in the newsletter as well, but we've got our EDMD peer support team. You can see the phone numbers for each individual person who signed up for that. We have our physician and family support program, so there's the phone number for that. And then just a quick reminder about our Slack channel. There's tons and tons of different channels on our actual platform. So there's nutrition and workout suggestions, ways to help if you're on self-isolation and want to get involved, people who have spare accommodations if you need to isolate from family, reflections on cases or difficult interactions, or just things that have been sort of difficult. And then there's also a channel to celebrate successes. So please make sure to check that out. Next slide, please. So this was also in our newsletter, just a quick reminder in regards to the Center of Sleep. They are there to support us. They're there to support our nurses and support staff. If anyone does reach out to you to say that they're having difficulty from a sleep perspective, please identify yourself as an EM healthcare professional. You'll get in significantly faster. They're working very hard to see people sort of next day, and it's a self-referral system. So the links are up there on the slide, and then they're also in our newsletter. Next slide. So this is sort of keeping this nice and short in terms of our wellness update. So while I am on the Wellness Hub, and I'm in complete amazement of all of the amazing co-hub members and what they've sort of shared so far, so mindful exercises, different apps that they're using, and all this literature that they sort of have on their fingertips, I really have learned a lot from them on all these different resources. But to be honest, I find those resources to really be out of my comfort zone. I struggle with the idea of meditation. I struggle with breathing exercises. I can't really connect to them very well. So I just wanted to take sort of a step away from some of the already formatted, already put together resources that are out there, and just sort of share some pragmatic tips and tricks that I've gathered from a few other colleagues that myself and then some of them have also been using sort of to support through this crazy time. So the first big one is giving myself 2 moments, about 5 minutes each a day, to just wallow. And so Nadim had sort of talked a little bit about this last week, but allowing sort of for your anger, your grief, you know, the frustration of missing workout classes, inability to see my friends and family, the real fears of getting sick, potentially having to postpone my wedding, all of these things. I just wallow in it. But then I finish off that wallowing session and I text either a friend or family member one thing that I'm grateful for. So it allows me to sort of rephrase my thinking into more of a positive thought, but still allowing for some of that anger and grief and sort of sitting in that. I think the second big point is choosing when you take in all the badness. So whether it's our email inbox, Twitter, the news, even what used to be happy in terms of our social media, so things like Facebook and Instagram, everything is just now filled with COVID. So stats of the infected and dead around the world, healthcare workers speaking on their experiences, events that continue to be canceled around the world, and all the travel trips and everything that continue to be canceled. And it can be really, really overwhelming and really saddening. We obviously need to read our emails to be updated for safety at work, and it's hard to avoid all the news or the updates, but put some boundaries on how long and when you're consuming that information. So especially reading this information before bedtime, I know a lot of people are having difficulty with sleeping. And so this is a way to sort of move taking in all of this information into earlier on in your day to help with that. And I don't let myself read sort of the news or Twitter for longer than 30 minutes a day anymore, just because it gets too overwhelming. For me, working out has always been one of my biggest outlets, but it's obviously become much harder, mostly because I'm motivated by others around. So I love working out in a gym or group fitness classes. And I live in a condo, so there's limited space for that full home gym setup that I've seen a lot of people sort of posting and talking about. And not all of us have a climbing wall in our house. I won't name who that is. But for that motivation piece, I now text a friend when I wake up, when I've got a plan for what the workout is that I'm going to do that day. I either plan to do that virtual workout at the same time as that friend, or I have an accountability text from them to make sure I actually did it on my own. The Slack app has shared, and lots of people have shared different home workouts or apps that they use. And so make sure to check that out for some other options. And then lastly, obviously a lot of us are also missing, though we're very fortunate to see a lot of our friends and family at work. But we miss being able to go out and actually meet friends. The whole sitting at home thing is getting pretty old pretty fast. So one of the things that I wanted to share is the House Party app. There's just a little picture on this screen of what it looks like. It's an app you can download on any smartphone. It's sort of like Zoom or Skype that it allows you to video chat, but there's also these amazing games like Pictionary and Ellen's famous Heads Up game and things like that that you can play. You can have up to 8 friends, and it sort of feels like a games night out. You can sort of share some cocktails and things like that. Of course, just FaceTiming and Skyping or Zooming your friends or loved ones are also amazing. And it just feels really different from picking up the phone and calling them. Next slide. And then the final thing I just wanted to remind you guys of, this was also in the newsletter, but we are going to be doing a wellness challenge. It's a meme challenge. So submit your best COVID related memes for a chance to win. Just send them to Sarah McPherson. Her email address is there above, or below, sorry, and tune in to next week to see all the submissions. And that's it for me. Just remember that you guys, we're all available. We're all there. So reach out to all of us if you guys have different concerns or things like that. Thanks so much.
Thanks, Farine, for that wellness update and to the rest of the COVID working group for kind of their content. So as Stuart mentioned, our goal from the COVID working group is to try and provide some direction. And in this case, to try to provide maybe a bit of a reassurance with some attention to specific things that we can optimize within the realm of kind of area management for these patients. We're going to try and do this in the next 20 minutes and not burn everyone out on too much COVID material. This is by far not going to be exhaustive, but we're going to start the process, and there will be future updates kind of as needed. And so with that, if you want to advance to the next slide. So when it comes to the COVID-19 area management stuff, essentially we're trying to balance the risks of what we do every day, which is managing, fairly hypoxemic patients and hypoxic respiratory failure, versus doing this in a very different environment. And so one of the primary goals of this update was to really address some of the concerns, to say, there's not a lot of differences within the realm of area management. It's just that we're doing it under a little bit of duress. We're in full PPE, which we're not very comfortable in. There is a chance of exposure, and we're taking appropriate precautions. And essentially, we're doing it in a little bit of an austere environment. And so just to kind of remember that, because there's kind of a risk balance, a risk benefit there for both patients as well as our healthcare When it comes to PPE, you know, the next slide there, Aaron. When it comes to PPE, you know, these are something that is very novel and unfamiliar for us. We're not used to having such attention to detail, and it's probably a good thing that this came around, and we're all going to be very good at dealing with that PPE. I want to refer everybody to the AHS standards for kind of donning and doffing. We're not going to do any significant content today on PPE specifically. All we wanted to emphasize is that we are using a WHO and AHS approved process for this. We are, you know, within the realm of airway management, there are, you know, things that classify as AGMPs, and we are taking appropriate precautions and using, you know, world experts to guide us as far as doing these procedures in a safe way. And that just to make sure that we pay particular attention to doffing. There's lots of resources out there from AHS regarding how to do all this appropriately, and I encourage everyone to kind of update themselves on a regular basis. Next slide. When it comes to AGMPs, so we're going to talk about the airway management, and there's certainly lots of aspects of airway management in COVID positive patients, which can technically classify as an AGMP. You can see the list there, but I want to remind everybody that if we are going into these you know, patients' rooms in full PPE, that's appropriate for AGMP generating procedures, we're going in there to do an AGMP, which is oftentimes providing some assisted ventilations, and ultimately ending in potentially securing an airway and positive pressure ventilation. So in that case, we want to minimize these things as much as possible, but we're appropriately protecting ourselves and the healthcare team, and that's kind of a major point that I wanted to get out there. Regarding AGMPs, there's been a lot of questions about what kind of classifies. If you go to the next slide, I've got a document that Tona, one of our wonderful RT educators from the Foothills, has put together. And in general, if you want to think about it this way, because there's been a lot of questions about kind of flow rates and oxygen delivery, dry oxygen, meaning the flow that comes out of the wall, is not an aerosol generating medical procedure. You know, nasal pumps set at 6 liters with a high flow nasal cannula that go up to 15 liters from the wall, simple masks up to 5 or 15 liters from the wall, as well as a non-rebreather mask. None of these are considered to be an airway AGMP. You know, we'd like to minimize flow rates as much as possible, and certainly the more flow you turn up the wall, the more you kind of have that background noise of flow rates, which again in full PPE and in the environment may kind of add to the whole anxiety in the situation. But just remember that any oxygen delivery from the wall is safe. We're advocating for somewhere around 5 to 6 liters through your nasal cannula, with about an additional 15 liters plus or minus coming from the wall to supply your either non-rebreather or your bagged out mask. So upwards of 20 to, you know, just above that as far as flow rate from the wall is totally appropriate. But we are going to try and limit and not crank these things max to say 30, 40 liters from the wall as much as possible. Wet delivery of oxygen, however, which we can call humidified, is considered an AGMP. So these are cold nebs. These are any nebulized medications. And then more specifically, our Optiflow or Airvo, which are our heated, humidified, high flow rate oxygen delivery devices, as well as things like BiPAP and CPAP. And so those are the things that we do consider to be an AGMP. Speaking of some of these humidified sources, when it comes to non-invasive ventilation, there's been a lot of questions about this. And so we just want to provide a very brief update as far as things to kind of think about. So when it comes to non-invasive ventilation, thankfully we've had Dr. Kristen Fraser, who's a respirologist at the Rocky Hospital, has taken a leadership role in developing documents to help guide us here. This was, I think, emailed out to everybody as recently as last night or this morning. So I encourage everybody to have a look. In general, I think initially there was a lot of anxiety about using non-invasive just in general, considering it was an AGMP. You know, we certainly do need to be using BiPAP specifically for the patient populations that are going to benefit from it without increasing risk for our healthcare workers. Some of the things that we've learned though. So number one is we do not need to be in a full negative pressure space. We have guidance through Dr. Fraser as well as through IPNC to suggest that as long as we're in an isolation space where we can close the doors and people are in our appropriate PPE, then you can certainly use BiPAP in those environments, but it doesn't necessarily have to be a full-on negative pressure space. Going on to kind of patient selection for non-invasive, you know, if you're in our goals of care, you know, so COVID positive and or suspected patients, You know, we know that there's a high risk of failure from non-invasive ventilation. So, you know, if you have an our goals of care, then it's certainly a consideration. But in general, as people fail some of those more simpler methods of oxygen delivery, we know that they're moving towards potentially needing mechanical ventilation. And so just to remind everybody of that, and to make sure that we involve ICU to help kind of decide that. And then again, depending on resources, there's also potential for these considerations to change. I think more importantly for this particular time is going to be consideration for BiPAP people who have that M goals of care. And so I think the REST group and Dr. Fraser have certainly helped to show us that when it comes to hypoxemic respiratory failure, in general, people on non-invasive ventilation don't do well with that, regardless of their COVID status. And specifically when it comes to COVID, we know that that's going to be true. So there's really no role for using BiPAP in an M goals of care patient when it comes to hypoxemic respiratory failure. So your COVID positive patients, your pneumonias, and other things. One quick caveat to that would probably be, you know, a primary presentation of pulmonary edema or flash pulmonary edema, where BiPAP and a trial of BiPAP can be used until other, you know, definitive treatments or other treatments for heart failure begin to work, and then certainly trying to get people off of that non-invasive treatment as quickly as possible. So that would be one exception in the M goal of care patient. And then what we really want to make sure we don't do is avoid using BiPAP for those people and those patients where it's going to do significant improvement for their illness. And so hypercapnic respiratory failure, so our COPD patients, what our REST group is advising is that we do a trial of 2 hours with reassessment. And so the literature before all of this is fairly clear in the sense that if people aren't improving after that 2-hour trial of BiPAP from an acid base in clinical status, then they're unlikely to do better without, you know, formal mechanical ventilation or endotracheal intubation. And so in these people with the M goals of care, after a 2-hour reassessment, to limit the amount of BiPAP and risk to healthcare workers, we would suggest talking about comfort care or palliation, or stabilizing them on other things that are not non-invasive if possible. And then certainly for our C goals of care patient, there's really no role to be talking about these sorts of things in general. And so hopefully that's some guidance. And again, I refer you to that document, which has been vetted through ZEOC and through AHS mechanisms to help to guide everybody. Moving on from that, there's some additional documents that I want to show everybody. If you can go to the next slide. So moving to the next slide, just talking about some additional documents that we have available for you guys. So the first thing you see there is our typical adult airway management pause, which has been something that you've seen me and others like Hoffman and Tona from RT go through in previous presentations. We're still advocating that people use this management pause to help as a cognitive tool during airway management. The other document that you'll see that's being packaged with this airway management pause is the zone-wide airway management best practice considerations, which was a multidisciplinary group, many different stakeholders, spearheaded primarily by John Gaudet from ICU, who is saying, basically just providing some guidance as far as the best practice considerations and certainly the best care for patients from a COVID-19 positive status. You know, it talks about preparation, positioning of your team, your intubation plan, and your post-intubation reminders. This will be available by our website, so people can review this. I encourage people to review specifically this best practice considerations ahead of time, and to kind of mentally rehearse and go through this process. And I think this tool is a good addition for review and it may change as well. So it's a living document which will provide ongoing guidance throughout this. We're going to move to the next slide. We locally also have an airway management algorithm, which you'll see here. It's got some very subtle changes when it comes to COVID-19 positive patients. But ultimately, this is just a reminder to say that, you know, we really want people to plan ahead. One of the things we've simmed in these patients is that there is certainly a limitation to getting new and different equipment in the room once you're all set up for managing these people's airways. So we really want people more than even normal to think about your plan B, think about your exit strategy, which I talked about before, and think about your emergency strategy, and to go ahead and plan appropriately for those things. So continuing on, so we've got our, our algorithm that you guys see. And again, this is something for review ahead of time, just to kind of walk yourself through this process and to say, hey, if my primary approach is unsuccessful, and I'll get into some details, making sure that you're very much essentially in these isolation rooms to plan appropriately for your second, other attempts, your exit and your emergency strategy, as you would for any encountered difficulty. We can go to the next slide. The first thing we want to let everybody know is that, you already do have the skills that are necessary. So there's nothing new or dramatically different outside the kind of precautions that we're taking when it comes to managing these patients' physiology. And so we just want to make sure that we focus on a few things and pay with way more attention to detail. One of those, of course, is the team. So you'll see that I've got the scales here. It's a balance of our risk to our team and our risk to our healthcare workers, and minimizing AGMPs and trying to do this in as smooth, as safe as process, of course, while we're already protected with appropriate PPE. But then on the other side, we're balancing the risk to a patient when it comes to their presentation and their illness and hypoxemic respiratory failure, which we may see certainly in the worst case scenarios for these patients. And so it is a balance of these two things. And so we're trying to do this as safely as we can for both the patient, but as safely as we can also for our healthcare team. You can go ahead, next slide. When it comes to our general approach, and these things are the things that I would get you guys to, again, look through with some time when you want to look through some of the documents that we've posted. But again, appropriate PPE, we're in a negative pressure space. You've got your most experienced, airway manager. For sure, early on, considering expert consultation if there's any additional features of anatomic difficulty, or if you have time to plan for these sorts of things. Making sure you're getting all of your equipment assembled outside the room and ready to go. We've got pre-packaged airway kits, medication kits, and IV kits, which has been simmed beautifully, and upwards of 180 people of our practitioners have been through this simulation. Your medications via an RSI approach are available in those kits as well. You can use other agents if you so desired, but again, you're going to have to get this all ready ahead of time and make sure the team is aware of all of those things. Just a plug to say that we are using high-dose rocuronium for this RSI preferred approach, and so just to make sure that you plan appropriately for your post-intubation sedation, and make sure that, again, it's something that maybe comes into the room ahead of time. And then finally, from a general approach perspective, we are recommending video laryngoscopy. Again, decreasing the space that between the practitioner and the airway, decreasing potential risk as far as looking directly down the airway and AGMPs. I do want to tell people here that due to the recent DAM card update, you guys do have glide scope with the option of either a hyperangulated blade, which is the classic glide scope approach, but you also have the option for a MAC geometry, a MAC 3 or MAC 4 blade with those glide scopes at all sites. And so you can ask your RTs for that. One quick caveat, which is to say we do prefer video. Glide scope is probably going to be the most common option, but if you want to use the MAC geometry blade, it's there. I would encourage you to make sure that you're very comfortable with this ahead of time. Certainly times of duress and times of stress are not the time to pick up a tool that you're not already comfortable using. And so just to maybe explore new techniques, simulate this, practice this, and then that's an option for you. Next slide. Also, when it comes to sort of the approach to airway management in these patients, we have shot a video, which is available on the Emergency Medicine COVID-19 resource page, entitled on YouTube, the Calgary EM Department's COVID-19 intubation. This is a short 5-minute or less video, which runs through the process at the point of PPE in place of doing a little bit of a pre-entry timeout or checklist before you walk in the room to make sure you have all your equipment, and then moving through the process of oxygenation, endotracheal intubation, and attaching a patient to the ventilator. It is an example of a more straightforward approach from a COVID-19 patient, so awake, spontaneously breathing, but significant hypoxemia. Certainly there's going to be other variations on these patient presentations which we will see, but this is a starting point to kind of get people to walk through the process and see some of the specific attention to detail and specifics regarding oxygenation that we're encouraging. So I encourage you all to check that out. I'd also encourage you to watch this video and in conjunction with reviewing some of those other documents, the best practice considerations, the algorithm, and the airway management pause, and just mentally rehearse the process ahead of time and maybe on an ongoing basis throughout this pandemic. So a couple of things we want to highlight here. Many people have done some work standardizing the equipment that we're going to be using to make this as safe and as cognitively easy as we can. So again, this is our pre-assembled BVM circuit. As you can see, the green HME/viral filter is in line with your face mask, and there's inline suction already there. This allows us to face mask or bag valve mask ventilate patients with a viral filter in place, and then quickly transition to an endotracheal tube with all the circuits pre-assembled, and so there's no unnecessary reconnections or disconnections, certainly once the patient's been intubated. So just to be comfortable with that. Next slide. When it comes to oxygenation, again, the primary issue for these patients is, this atelectasis and this shunt physiology. And so, an oxygenation is your primary approach. So again, for your spontaneously breathing and your compliant patient who has adequate ventilation, we're going to optimize positioning. We're going to get them in a sitting up position and maximize their FRC if possible. We're going to use nasal cannula underneath the face mask with a BVM and a PEEP valve. And we're going to do what we call passive oxygenation, the idea that we're going to allow spontaneous patient breaths and maybe encouraging large breaths with a good seal on that mask. There is a filter in place, so if you have a good seal, then this is obviously a very safe thing to do. And we're going to encourage oxygenation by spontaneous breathing with that PEEP valve and a good seal for a significant period of time. And certainly you can titrate your PEEP during this time as well. We're going to minimize leak, and then, like I said, really, really spend time allowing the patient to spontaneously breathe and not squeeze the bag or not provide any positive pressure ventilation, because this just does increase the risk of an AGMP slightly. Next slide. In as comfortable way as possible for the patient, having them potentially, if sitting up if possible, providing a good mask seal with a PEEP valve, those nasal cannula underneath, and certainly allowing as much pre-oxygenation as time and stability allows. There's a couple caveats to this. So one that we're seeing is that there's often people are agitated due to the stage of illness that they're in or their hypoxemia. At this time, we'd say consider some medications to kind of encourage that pre-oxygenation strategy, or some medications to encourage compliance. Typically in the literature, we're talking about very small doses of ketamine or the idea of a DSI. Again, best case scenario, if they're agitated, you're able to provide some medications and then still passively oxygenate, relying on their inherent respiratory drive to oxygenate and avoiding as much as possible squeezing the bag or providing positive pressure ventilation during this period. If you do have to provide some additional ventilation, so examples would be somebody who is now inadequately ventilating on their own and you have some concerns about their oxygenation status, then just make sure that we go slow and keep your pressure low. When it comes to squeezing the bag, we call this more active oxygenation, providing positive pressure breaths. If you're going to be doing this with some degree of patient breathing on their own, then certainly the timing of this is really, really important, because again, we don't want to have any dyssynchrony leading to more of a mask seal or leading to gastric insufflation. And so just to be very cognizant of this, again, the best provider, whether it's the MD or the RT, to help in this kind of more delicate procedure of timing the breaths during to supplement someone's respiratory mechanics. Okay. So again, moving towards kind of the process of RSI, we prepared this video which walks through some of the steps. We don't have time to go through the exhaustive nature of a stepwise process for this, but use this in conjunction, this video in conjunction with the best practice consideration guidelines, the ICU document, the care of the adult critically ill COVID-19 patient, as well as your pause and that algorithm. And all of these will be available on the website for you to review. Next slide. So one of the things we have to address specifically is, in a perfect world, we're able to have the patient spontaneously breathing, adequately oxygenating, and then we can proceed by RSI and getting a secure endotracheal tube and not providing any positive pressure until that cuff is inflated and secure. There may come a time if a patient presents with significant hypoxemia where we may have to re-oxygenate. And so the idea here that once RSI medications have been delivered, we might need to provide some positive pressure ventilation for hypoxemia to allow us to then continue on in our airway management strategy. So if this is necessary, again, all of this is a risk benefit. The numbers in the best practice considerations are SATs less than 70%. You have to use your judgment here. Numbers are a good guideline, but certainly use your judgment as far as when you might need to step in and provide some positive pressure ventilation with the bag valve mask device. We want to make sure that everybody does two-person, two-handed technique, and again, going slow and keeping your pressure low to again minimize your leak and just to make sure that this goes as smoothly as possible. So again, this is our good Dr. Patty Lee showing us this two-handed, two-person technique. So again, we call this a VE technique, or with those big thenar eminences close together on the mask, and then using the remainder of your fingers under the jaw to exaggerate a good jaw thrust and open the airway as much as possible. And again, one person, best person doing that two-handed seal, and then another person with gentle pressure and slow pressure on the bag to facilitate providing some degree of positive pressure ventilation. And again, this would be in the setting of having to re-oxygenate a patient should they desat during an attempt. Next slide. This is a plug for your algorithm to just say that, if we're getting to a point of re-oxygenation, there we're already into our plan B attempt. And making sure that if you at all felt it was necessary, then for sure expert consultation as time and availability allows. Two, making sure you very much plan ahead for your exit and emergency strategies, because again, these things may happen very quickly, and certainly you want to have the equipment available. So I encourage you to review this algorithm as I've talked about before in other talks. New paragraph. When it comes to specifics from an exit new slide, please. When it comes to specifics for an exit strategy, I want to make sure that everybody has thought ahead to plan that your best and quickest exit strategy and just providing oxygenation to these patients is going to be a good two-person, two-handed approach to bag valve mask ventilation with as best a seal as possible. If you can do that, then you are appropriately protected with your PPE, and certainly you have some time to consider other methods or a plan for having some additional help come to the bedside. We do know that an IGL or other supraglottic airways can be useful here, and so that doesn't change in COVID-19 patients. Again, as best a seal as possible certainly is the goal. And making sure that we call for help if it's not already done. There is some evidence that came out of the Canadian Anesthesiologists Society webinar that if your first approach for a supraglottic airway isn't adequate, then a second device seems to work in many patients. And I think this mostly just has to do with the degree of leak and being able to adequately oxygenate people. So we do have iGels as a first line approach, and there are also LMA fast tracks on our difficult airway carts. And so just some consideration to these things, keeping in mind, next slide, that if at any point, we are having difficulty oxygenating and you're now in a point where you can't oxygenate and we are not been able to get a secure endotracheal tube, then you have to think about your emergency strategy. And again, your emergency strategy is not different than any other patient as you move down this algorithm. And typically we advocate for a bougie-assisted approach, specifically a scalpel finger bougie based approach, again, which you guys have heard me talk about before. Next slide. So there's been a lot of questions too about, in which situations do we need to clamp the tube? We've prepared these circuits ahead of time so that there's a viral filter in place for both face mask ventilation, and then quickly transitions to having a secure. Once the secure endotracheal tube is in place, there's only one disconnection to attach someone to the ventilator, and this connection happens with the viral filter still in line with the patient. So under these circumstances, you've got a viral filter that is in line for most of this airway management procedures. And so it's not necessary to clamp the tube for that single one exchange. Inline suction has been put ahead of time onto that circuit so that we don't have to disconnect at downstream of care to be able to facilitate suction. There are a couple exceptions to this. So the biggest one is if that filter needs to be exchanged, whether it's blood, vomit, or moisture, that's something you might consider clamping the tube. And I would defer to your RT colleagues to help you facilitate this. The second one would be to maintain lung recruitment and PEEP if you have a patient who has very significant hypoxemia and shunt physiology. And so that would be a consideration, regardless of where the filter is, to maintain that lung recruitment when you're making disconnections from the vent. Next slide. When it comes to the need for critical care and mechanical ventilation for these patients, we know that there really isn't a threshold of flow rates or a threshold of an FiO2 that mandates critical care in these patients. Clinical judgment and very patient-specific decision-making is necessary to sort through who's going to, which patients are going to need positive pressure ventilation during their illness trajectory. One thing that has come up in some of these conversations is that it's more about patient trajectory, which is a sense of a pattern of escalating oxygen needs in conjunction with other factors and other clinical data points. Probably will identify those that need mechanical ventilation. And this is obviously going to be balanced with the fact that it's very much safer to manage these patients from the procedure of intubation when they're identified early in that illness trajectory, before there is no wiggle room when it comes to oxygen needs. And so again, balancing those two things, the patient's trajectory of increasing oxygen requirements as well as other clinical factors versus the need to be getting people involved early so that we can manage airways when it's safer to do so. Next slide. Just a couple more slides here to kind of tidy up a few common questions. So CPR has been a common one. Your team should be an appropriate PPE if there's CPR ongoing. EMS has been instructed to continue to hold ventilations, but to continue CPR if they're coming through the department. It is technically an aerosol generating medical procedure, so inappropriate PPE. In this situation, then, A truly does come before B and C in a lot of circumstances. There's some evidence from ILCOR to suggest that defibrillation on its own is probably not a significant AGMP. Specifically nowadays with pads on the patient, you can be standing at quite a distance away during defibrillation. So again, if you've got somebody in a shockable non-perfusing rhythm, there is the idea that maybe we should proceed to that as quickly as possible. Hopefully PPE is in place. But that in general for these patients, we should consider airway management with a secure endotracheal tube as early as possible. If there are significant delays to being able to do that, then I would say it's reasonable if you're in appropriate PPE to continue CPR until you're ready to manage that airway. But while the airway is being managed, which is again different than on my classic teaching, we should hold CPR for that airway management to again minimize the risk. And then restart it once there is a cuffed endotracheal tube present. And then finally, just a reminder to say that, if we do have COVID positive patients with a, arrest or peri-intubation arrest, this is very much likely to be hypoxemia driven, and the focus should be on oxygenating these patients and whatever the balance of risks shakes up there, but just providing oxygen in whatever way you can do effectively. And then the last question that I've been getting frequently is what to do about supraglottics, which in most cases is going to be supraglottics coming into our department by EMS. And this really isn't that much different than how I would tell people to manage most supraglottics. You need to ask yourself a few questions and perform a bit of a risk analysis. So the questions that I kind of quickly run through are, why was the supraglottic placed? Was it because of a lot of difficulty intubating? Were there some anatomic features of difficulty that prohibited, for an initial attempt? How much trauma was done to the airway in the process of either intubation attempts or from the placement of the supraglottic? This is an uncommon one in our environment, but how long has it been in place? Because we do see, especially with the inflatable devices like the King LT, is a certain degree of edema that occurs over time, which leads to a lot more anatomic difficulties. And then just another couple questions about some of the situation, like, is there a significant leak or is it working very well? Currently what's RFiO2 and the pressures being used to ventilate these patients and the overall clinical status. And so asking yourself these questions will allow you to then do a bit of a risk analysis. If it's very low risk, then I think it's better and safer for the patient to have a secure endotracheal tube in place, as well as better and safer for the team. And so you should consider moving through kind of an RSI process like we've kind of described and as demonstrated in that video, with maybe a few alterations. And if it's a very high risk situation based on some of these questions you ask yourself, then certainly the risk to the patient is quite high. And again, if you're an appropriate PPE, the risk to the healthcare team is relatively low. And so maybe changing that airway out in a more controlled environment, like the OR or an ICU consultation to help facilitate that would be reasonable. And so just a few considerations.
So Brian, I think just maybe in the interest of time, and I see that some of our numbers are dropping off, I think maybe what we'll do, if you're okay with that, is that we'll try and address the questions that have not been covered yet in the notes when we post this update. So if there are any other questions that people want to submit, and any questions that have not been answered adequately, please look for the notes. Sean's going to be working on that. Brian's going to be working on that to answer your questions and have that as a reference along with the links for the resources that have been discussed. Okay, Brian?
Yeah, that sounds great. Please send any questions along and we'll continue to address some of these. And if there's any further updates, we'll do something similar in the future. Thanks for your attention, everybody.
Absolutely. I just want to thank Brian for that. I was just thinking that it's such an awesome, you've covered so many really pertinent questions that a lot of people are asking. So that's some clear guidelines. Thank you. And then everybody's commenting on what a wonderful moustache. Okay, so just to wrap up, next week's clinical focus is going to be on PPE. So please send in any questions that you have, burning thoughts that you have about PPE, and we will try and get a panel together to answer those questions next week, specifically to that. Please check the webinar for the Q&As, and then remember the Spectrum app is out there. Spectrum app is being updated. It has a lot of COVID-specific information. And I think unless anybody else has anything else they'd like to wrap up and say, I'd just like to thank the working group again for all the work that they've done. Anything anybody would like to say, Sean?
Stu, just to remind everyone, the emergency medicine website at our Calgary Emerge website has all the relevant documents. So the airway stuff that Brian just presented, the video that he was referring to, as well as the COVID's workflow pathway in terms of who to consult and what, that should be the source of truth for COVID-related documents for both adult and pediatric Emerge documents. So go there this afternoon and it'll be updated with the information we need.
Perfect. All right, guys, so I think we're just going to wrap this up then. Thanks a lot to Brian for all the work he's done. Thanks to Fareen, thanks to Neil, and then thanks to Sean. Goodbye.